Here during session. I'm going to go ahead and call the meeting to order, and Becky, please take the roll.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll, Senator Douglas,
Present.
Senator Elkins,
Present.
Senator Funky Fromeyer, Senator Nemes,
Present.
Senator Tishner, present. Senator Wise,
Present.
Representative Bentley, Representative Bratcher,
Present.
Representative Bray, Representative Burke,
Here.
Representative Callaway,
Present.
Representative Dotson, Representative Duvall, Representative Frazier Gordon,
Yes, ma'am.
Representative Justice, Representative Neighbors,
Here.
Representative Palumbo,
Here.
Representative Raymer,
Here.
Representative Riley,
Here.
Representative Rourks, Representative Sharp, Representative Weber,
Here.
Representative Wilner, Representative Witten,
Here.
Co-Chair Meredith,
Present.
Chairwoman Mosier.
I'm here. Okay, we have a quorum established to do business, and the first order of business is approval of the minutes of the September 27th meeting. We have
Second.
a motion and a second. All in favor of approving, please say aye.
Aye.
Okay, any opposed? All right. Okay, we will move on with our agenda. Okay, good. All right, the first order of business, or the first testimony, is I'd like to introduce Dr. Francis Feltner and Matt Coleman to give us an update on the Healthcare Worker Loan Relief Program of the Commonwealth. Thank you for being with us. If you could please introduce yourselves for the record and proceed.
Good morning. I'm Dr. Feltner, and I'm the Director of the Center of Excellence in Rural Health located in Hazard, serving all of rural Kentucky, and thank you for having us today.
I'm Matt Coleman. I'm the Director of the Kentucky Office of Rural Health located in the UK Center of Excellence in Rural Health. Again, thank you for having us today.
All righty. So just to give some background information, this has been a wonderful opportunity, and thank you, Representative Moser, for representing us here to do this today. Primary care physicians, when we look at workforce study at the center, I wanted to give you how we consider an active physician in the state of Kentucky. First, just to give a little background. When we do our workforce studies, we calculate the number of physicians we have by active status in Kentucky. They're working in Kentucky. They're hospital-based. They might be private practice, adolescent medicine, family medicine, general medicine, and internal medicine, and pediatrics. That's who is counted in our numbers. When we look at the state of Kentucky, we have over 10,000 physicians practicing in Kentucky. And I broke this out by rural, urban, Delta, and Appalachia just to show you the percentage of physicians we have providing care in the state of Kentucky. And if you notice, the biggest number of physicians are located in urban Kentucky. Rural is next to that, and then Appalachia, and then the Delta region, the number of physicians that are practicing there. Also, when you look at the primary care providers that are located, and you look at the population that they serve, when you look at HIPSAs, and you look at the need in the community, you look at, like an example, a physician in that first one in urban would see 1 to 331 patients with a ratio of 1 to 1,500. When you drop down to Appalachia, you look at a physician has to see more patients at 1,800 patients. And so it is more of a burden when you have less physicians providing services for the people in those counties.
If I can stop you for just a second,
Sure.
HIPSA is the Health Provider Shortage Area.
Yes, ma'am. Thank you. I should not use acronyms here. We're so used to all of these ABCs. So if you look at the physicians that are licensed in Kentucky, Most physicians that are practicing there have been licensed 11 to 20 years. That's 26% of them. And when you look at a third of them practicing in Kentucky, 31 of 50 plus years, 32% of them have been practicing. Only 17.1% have been licensed less than 10 years. And there's a reason why I'll show you that here in just a second. And when you look at the distribution in our map of our beautiful state of Kentucky, the brighter the blue is the more physicians that are practicing. And again, that just shows you where urban and rural and Appalachia and Delta regions are in the state of Kentucky as far as the physicians. Also, when you look at the map, you see some white spots on the map there. There are 8 counties in Kentucky that do not have a practicing physician in those counties. When you look at the increase and you go back to the year of 2016 and 2017, we did have an increase there of 54 physicians added to work in Kentucky. In 2018, when we dropped down, we had 75. But what I want you to see is in 2020 and 22, where we had a negative amount of physicians that we had practicing in Kentucky, that we lost 258 physicians and only gained 30 back in practice. And then we look at our nursing in the state of Kentucky, and we look at nurse practitioners. There are 69,000 RNs in Kentucky practicing, according to the licensure data. There's 2,400 APRNs practicing in Kentucky, according to license. And when you look at their work setting, they're in the office or in the clinic. They work in hospital inpatient. They work in ambulatory care. And then when you look at their focus, they are working in family medicine, they're anesthesiologists, or they are family psych and mental health. Also, again, when you look at our state, as far as rural, urban, Appalachia, and Delta, you see that in rural, we have less RNs, we have less APRNs, we have more in urban area again, and when you drop on down to Appalachia and Delta, those numbers decrease again. I've wanted to bring the dental part in here because it's very much part of our health care that we do. Somehow or other, we have to keep our bodies all together, and our teeth are part of our bodies. And so if we have good dental care, we have good health. So we have 2,546 dentists practicing. We have counties with shortages, and you can look there. 5 of our counties have no practicing dentists at all. And all 5 of those are rural. And here is the map again showing, or the slide showing that 134 Kentucky dentists report working in multiple counties. In other words, they are either moving to those counties or people are coming to them from different counties. So there's 134. Again, you look and you see the biggest number of practicing dentists are in urban. And then when you look across our state again, the darker the blue is, the more dentists there are practicing. And then you can see that 16% 75 of 120 Kentucky counties have 1 to 10 dentists working in them. 41% of all Kentucky dentists practice in Fayette County, and 16% in Jefferson County, 25%. So today we're going to talk about the loan opportunities that we have for our physicians and our nurses and other folks that are practicing in our state of Kentucky. And these are opportunities. We can think of a lot of ways to retain and recruit our practicing providers in the state of Kentucky. And these are 2 that we're going to talk about. And at this time, I'll turn it over to Matt.
If you don't, I'm actually going to go back just a second. So we're going to be talking about the Healthcare Worker Loan Relief Program of the Commonwealth. So that is the state funds that have been designated to the Center for Rural Health in order to provide loan relief. And then there's also the Kentucky State Loan Repayment Program, which has been historically handled by our office at the Kentucky Office of Rural Health for the last 20 years. Historically, just kind of a quick background, the Kentucky State Loan Repayment Program in the past has operated. It's first of all, it's federal funds, and then we go through a process to apply for that. And then there's a match requirement for those funds. So one, we will designate funds to those providers, but also there's a match by the organization that is employing the provider in order to keep recruitment and retention in those areas. So that's kind of the beginning of that. And so we're going to talk about some of the great flexibility for the state funds that have been provided. So I understand this is small font. I apologize, but this is kind of one of those like quick slides that we're trying to show you. Here are the eligibilities for those two programs. And the best part about the Healthcare Worker Loan Relief Program of the Commonwealth, those state funds, is that it provides a little more flexibility for practitioners. So we were able to add different practice types just because state funds are a little bit more flexible than those federal funds. We have to operate by those federal guidelines, as you understand. So we've been able to use that in a different way, and we're continuing to work on that. So kind of some of the challenges real quick. So we're going to go from challenges to achievements, because it started off with challenges, and of course we've worked our best to turn those into our achievements. So as we have two programs, if you've ever tried to combine a federal and state program, you know that that's really extremely fun and exciting, right? So the navigating that and understanding what the guidelines are and figuring out reporting dates. We have different fiscal years for federal funds as state funds, and just trying to make sure that we're able to use both sets of funds together and mesh those two different processes. So we'll talk about that in just a second, talk about the best part of that. Time to get the program set up. Just what it takes in the first place to start a program from zero. I understand that we had the federal funds, but we had to start from the ground up with the state funds. And then, like I said, the reporting process, and then the application process. We had to align the different application processes of both the different types. Identifying entities. So this is our biggest challenge, is what we wanted to do is find a way to use state funds to help stretch the federal dollars and the state dollars to provide a match for some of our providers and some of our clinics that were not able to provide those matching funds, as I mentioned. And then just the general incomplete applications, making sure eligibility, a lot of just the general, like what comes with an application process. Those are challenges. And while we have staff members who can address that, sometimes it comes past the deadlines, and we try to be as flexible as we can. But at the same time, this has been a highly competitive process across the state. So
To add to that, one of the difficulties we've had, excuse me, is determining like who can pay the match. You know, a lot of the programs that have federal fundings do not have state dollars to help with that match. And if a small rural clinic has to come up with $50,000 for a match, that's really hard to do. But that's where they're needed the most. And so to be able to recruit and retain those folks, these dollars have been able to help us do that.
All right, so then we've also been able to expand, as I mentioned, expand some services that are not covered under the federal funds. So as we said, optometrists, ophthalmologists, audiologists, and some other specialties we're looking into, trying to ensure that we are covering what's not being covered, one, under federal funds, but also finding one of our biggest challenges is finding the need, not just geographically, but also by practice type, so in specialty. So this is just the historical, like what we have been able to find over the past 20 years, what we have funded, the different types of providers. So from 2003 to 2022, we have provided funds to 169 providers, not only from federal funds, but remember that's the matching funds too. So that gives you kind of the breakdown on what we have. And then this has been the past year and what we have funded. So we were able to provide, just for the Kentucky State Loan Repayment Program, we were able to fund 25 providers within HIPSA areas. So as you look through there, what we are looking at is reviewing currently. We are now in the review process for the 2024 year. And what we have been able to do now, because of course the fiscal years didn't really line up great this past time, but what we're doing now is working to stretch those federal funds and state funds, because we've been able to work together over the past year to find how to stretch funds to provide the match with the state funding. So that's part of the review process right now. So what we use is a separate board, of a group of reviewers to go through all that process.
When you look at this, one of the folks that we're having trouble reaching is our MDs that do want to have state loan repayment. And some of those were already covered in our federal dollars. And so now we're trying to reach out. We do have in review this time physicians and nurses in this review. But we've been able to fund 3 APRNs, 1 dentist, a licensed person to do the psychology. Mental health is really huge right now. 3 optometrists, 2 pharmacists, and 1 RN. One of the biggest issues that we've had, too, is getting the message out that we do have these programs, they align. A lot of folks knew that with our federal dollars, there has to be that match. And now we're letting them know about the way that we can help these small clinics be able to have a match dollars with their state dollars and stretch those. We do have a new cycle that we've just completed. They're in review. And we'll soon be able to push those dollars to the people to keep them here.
So here's a map. Again, it doesn't show up as great on the screen just because of how small it is, but this is the current awardees by county. As you can see, the blue is current awardees, and then we're stretching into the orange, which is current prospective that are under review. And as we can continue to add more, that will be added to the list. And again, then this is both the programs that are currently current awardees. So this is both state and federal funds being used within this program. And so this is part of the partnership of these are the ones that we are currently working towards reviewing to use both the state and federal funds in order to make sure that, again, we're stretching that. So these are the ones that have said, hey, our operation or our organization, they cannot provide the match for the federal funding. So what we have are currently doing is we're reviewing those organizations and talking with them to try to find out, okay, can we provide the match through the state funds in order to use both sets. And then just our future plans. Continue to provide these workforce studies. So every year, the UK Center for Excellence in Rural Health provides a workforce study. I think it was actually used at one point probably within this committee. So and then simplifying the application process, narrowing it down. We're constantly trying to evaluate. And then the targeted call for applications, as I said, by provider type and by region. We saw the maps. We saw, who has, small provider numbers in those areas. But also, if we're talking about specialties that are being ignored or having issues in those areas, we want to make sure that we're targeting those calls. So we targeted a call for dental just in this past year, and we're talking about mental health in other areas. And then so kind of I am necessarily new to my position here at the Center for Excellence in Rural Health, but one of the things that we have not done very well historically over the past 20 years with those federal funds is having an evaluation method. So that was one of the first things out the door that I wanted to bring into this. And so what we're doing is we're collaborating with the state primary care office, which works with the National Health Service Corps. They're kind of the overseer for the state, which is another loan repayment program. So there's 3 different types. So what we are doing is we have pulled all 3 different types to survey, and we're using the same survey so it's consistent across all 3 different programs. So in order to build this, in order to make it adjust it to what is needed by the participants and by the organizations that participate in it as well, we're having those surveys and evaluating. So that is starting in this year with the first year of those providers. So that's kind of our future and where we're going. But this has been a great start. And then from there, we're able to track recruitment and retention and see those actual numbers. So
We can tell you that with our I can tell you that with tracking our recruitment and retention, we have about an 80% rate of people that stay, that they get the loan relief, we recruit them in, and they stay where they're at. And so that is wonderful that we can keep 80% of those people still practicing. And that's the goal of this. Let's recruit them in. Let's get them here and keep them. And this is just two of the flyers that are on here that show how you can apply for both. One of the things that we really want to do is to make sure that this application process is a little bit easier than it has been. We have the rules on the federal side, the rules on the state side. We want to stay legal in what we do, but we want the application process to be better. And we also want to be able to reach more people to let them know about the program. And I think at that, we'll take questions. And these are just links to the reports for the studies that we do.
Well, thank you. I'm enjoying hearing this update because it seems to me that the program that we better funded in 2022 is working. Mm-hmm. I'm on slide number, I don't know, page 4. It's the just showing the number of physicians that primary care physicians that we're losing each year, either gaining or losing. And in 2020, we lost, if I can read this, it's so small, 38, I believe, and primary care physicians. And in 2022, we lost 8. Does that indicate a slowing of the loss? Are we making a difference in identifying those underserved areas and plugging those in with physicians?
That is a very good question, and hopefully that shows retention.
Right.
That we are keeping them in place. We don't want to lose 28. We don't want to lose 8.
Right.
So if we can use this program to keep people in place, that's what's so important.
Okay, that's great news. And can you just talk a little bit about the contractual agreements that individuals who use this loan repayment program are bound to? Just talk about that for a second.
So in the first place, if it is the state loan repayment program through the federal program with the 50-50 match, the provider has to pay, let's say I'll use $100,000 so it's easier to do the numbers. So if we do $100,000 for the physician, they get $50,000 the first year, and after they report, they're still in their same place, they're still working, they've been retained, they get the next $50,000, and their employer has to do both to keep them there. So there are reporting requirements for them. If they, it's just like a contract that we would sign, and if they go back on their contract, they leave, they're liable for the money that they got on the loan. And it's the same thing with the state dollars, that if we do the state match, they have the same obligation to the state. If they leave or if they don't fill their obligation on that contract, they have to pay the dollars back. So is that the question?
Yes. Okay. And they're obligated to work for an additional 2 years?
Yes.
Is that correct?
Let's say that someone actually has a loan that they owe more than the $100,000 covers, they can reapply again and stay another 2 years to receive the rest of those dollars in the match. So we can keep them another 2 years.
Okay. And then one more question. We've got some others who have questions. Can you talk about how those health professional shortage areas designations are targeted? Are there certain slots that individuals must move to, certain underserved areas that that you need to work in? You don't just get to choose.
Mm-hmm.
Okay.
Right now, do you want to do the federal side? Then I'll do the.
So yes, within the grading system that we have, what we do is when we go to review, we make sure what we take in is HPSA designation for that area, and that's added into the score of the overall review as they send it back. So that's part of that process for the federal side. Sorry.
Yes, and so on that too, he mentioned that we had the National Service Corps. We also have to run a report to make sure that they're not benefiting from National Service Corps at the same time that they're benefiting from these programs. You can't do both. And so we want to look at that. Also, it has to be a nonprofit that they're working for, and it has to be within that definition that the federal government gives us, it's also with the state. So we have to really be careful to make sure that we are following those guidelines.
Right. Okay. All right. Well, thank you.
Thank you.
Senator Meredith.
Thank you, Madam Chair, and good to see you folks again. Appreciate you
You
presenting
too.
this morning. I'm looking at page 2, your slide on physicians and PCPs. So 10,000 physicians are practicing in Kentucky. What's the data source for that?
Licensure data. It comes from the licensure data for the state.
So do we have that broken down, whether they're full-time, part-time, or
These are
just-
these are considered full-time physicians. Yeah. We clean the data up when we see.
Good.
I didn't leave that slide in there. But the way we clean the data, they have to be a full-time physician practicing there. We take out the ones that are maybe work a day a week. You do have some that are still doing that, but these are full-time physicians by licensure data.
do you know how many total physicians we have licensed in Kentucky?
Oh, I'll have to get back to you on that one.
Okay, appreciate that. And good information. What's missing, and it's not a criticism of you folks, is that, just put it in context, 40% of our population in Kentucky is considered rural, so it makes these numbers even more
It really does.
dramatic than it really is. And I congratulate you on your success on your slide on page 11, the number of people we had in 2023, but quite literally, we're spitting in the ocean. And I'm quite concerned we're not being aggressive enough with this, and I don't know where the challenge is, how it's going to be addressed. You said 80% retention. Over what period of time is that?
Over the period of our state loan repayment program with the federal government, because we've only had a year into this one.
Yeah.
But over the 20 years that we've had the federal program, 80% of them are still working there.
Okay, but outside of that loan repayment period, do we have any data that shows what that retention might be?
They're outside the. For the state, it's only been a year, so they have to be there 2 years. So they've only got their first year. We're getting ready to do their second payment, and they're all still there that we funded through the state dollars and through federal.
So for the federal state fund, or the federal fund, Kentucky State Loan Repayment, we looked at the past 70 recipients, and you've got to remember that tracks back 2 years at a time also. So we're finding that it's around 80% of those people are still staying into their current practice. So that goes back a few years. The problem is that stretches because of extensions. So some of those will be back, just a couple years, and some of those will stretch back as far as 7 or 8 years, and they're still currently in those practices.
But we really don't know what 5 years, 10 years out looks like.
And that's what we're trying to take into account with this evaluation. As I mentioned earlier, historically we had some issues with that, and as I came on, that's one of our first priorities, is to track that and evaluate it and see how far back we can go and track the results and see what those numbers are.
Well, I would look forward to that. Programs such as this have been around ever since I was in healthcare, starting in the 70s. And the issue that we don't seem to spend a lot of time talking about is retention of healthcare providers in rural communities. And with such a disparity, that's certainly an important consideration.
Absolutely. We do that with our students at the center, and before they leave, we get their contact information. Unfortunately, sometimes they do leave and we can't find them. We lose they move and we don't get their new email address or whatever. But we're hoping with these surveys that we can be a little bit more aggressive with that to be able to track them. Some people don't want you to track them down, but we're going to try our best to track every one of them.
Well, you have a wealth of experience in rural healthcare, and I certainly appreciate that and respect that. And I'm just curious as to, again, using the numbers, 40% of our population is rural, but only 25% of our primary care physicians are there.
Yeah.
What do you think that is? Why is there such a disparity in rural and urban?
I think a lot of that is to do with pay. You come to a rural area and the pay is not the same for physicians when you look at that. Just in my opinion of being in healthcare, the years that I was working, that has a lot to do with it. And then a lot of the amenities that are around in rural that you have access to. Housing is a big issue. Daycare, school, there's all kinds of issues there.
Well, I certainly share your opinion, and I do because we've talked about it before. And,
Absolutely.
I think the pay is probably the primary driver.
Yep.
Because again, you know my history. I've been successful recruiting physician in rural community, and they're staying there. And the biggest obstacle was providing them a paycheck that was comparable to their urban counterparts. So appreciate your opinion on that. That's all I have, Madam Chair.
Okay, thank you. Next, we have Representative Rourks.
Thank you, Chair. I want to say thank you for the presentation today, and Director Coleman, was happy to see the survey evaluation included. I'm one very big fan of an evaluation. You mentioned about awareness of the program and needing calls for applications in targeted areas by region or by provider type. What would that actually look like in practice? Would that mean direct outreach with folks that already existed in your network, or would that mean going to new groups or even doing a marketing campaign? What would it look like?
You take off and I'll hear.
All of the above.
Yeah.
One, we have plenty of partners and groups that we work with that also help us promote this. So in the past, we have not had that targeted call. And this is one of those where we work with those partners, the Primary Care Association, the KHA, all these different partnerships that we have, call on them and work together. I mean, it's a teamwork kind of deal, but yes, part of that is, driving those direct contacts, especially in those areas that we have zero anything. So talking to the counties around them even, to see where we can expand this and expand the word for this program. So we have plenty, like I said, capitalize on the partnerships that we do have, and we do have some marketing in there too. So
Another thing that we do is we actually go to the dental school to talk to the graduates. We go to the medical school to talk to the graduates before they graduate. I actually want to start down in high school about the programs and the opportunities that our rural students have in the future. A lot of rural students think they can't be doctors, think that they can't be nurses. We really want to reach them at an early age. We can't do this loan repayment with them at that age, but we can definitely let them know that there's ways that they can go to school and be able to become what they want to be. At the dental school, I had about 4 that wanted to get in the van with me and come home. And I was like, we need you here, here, here. And I think that's going to take a lot of FaceTime with people as well as marketing. One of the issues with the federal loan is that we can only have that go out twice a year. But with our state dollars, we can do that more times a year. As soon as we finish one campaign, we'll start another so that we can try to get the folks where we need them.
Excellent. Well, I know high schoolers definitely start planning their futures, and it's so important for them to know what that financially in the way of all the delayed life decisions that come with student loan debt. It's definitely a big burden and something that I know our youth are, thinking about, and their families are thinking about a lot earlier these days. So one final question was around, in your opinion, what do you think the biggest barrier to folks accessing the program is? And it might have already been touched on, but I just wanted to know, what do you think the biggest barrier is?
So historically, the biggest barrier is that match. And especially when we're talking about mental health care facilities have a hard time providing a match. So that was kind of our big push over the last year, was to look into ways that we can provide additional, whether it's marketing, whether it's talking with those facilities, finding a different way to work into that. So that's usually the primary care organizations. A lot of times they will have the match for that, but those mental health, as if you were able to look at a health designated shortage area of the Kentucky, our entire state is a shortage area for mental health providers. So that's one of those things that's high on our list, and we're continuing to try to improve in those areas. So that's historically what that is.
Thank you.
Okay, thank you. We've got a few more questions, but I know that you all do work with AHEC, and that reaches kids in middle school even, and high school, and helps identify those kids who may have an interest. So
Absolutely.
Just to make sure that our members remember that. And, as we work with KCTCS and some of our state school programs on things like dual credit, and obviously those are the kids that we can help identify as well. Senator Carroll, you have a question?
Thank you, Madam Chair, and thank you all for being here today. Just two really quick questions. Our friends at the Alzheimer's Association noticed that you all did not mention neurologists, and Kentucky is one of 20 neurology deserts in the country. Can you address that?
It is not one of the providers that is considered as far as the federal government is concerned on that program, but we can definitely do that in the state. What we said eligibility criteria is we added the optometrist, we added the others, and then we have special interest or special identified. We could identify that, so I'd love to have that information to look at because it is an issue.
Yeah, I'm sure they would be more than happy to provide that. The other question has to do with our managed care organizations. Has there been any communications there or any relationship for them to step up and help with some of the matching funding? They seem to be really good about spending a lot of money promoting their programs. This seems like it'd be a great opportunity to do that.
Have you had any contact that way? I haven't.
We haven't had contact. We would love to have contact at that. We'll mention that right now.
Thank you, Madam Chair.
Thank you. Senator Douglas.
Thank you, Madam Chair. I have two quick questions. They are quick. Thank you also very much for presenting this information. It's really interesting. I've been in the healthcare space for a long time, and I'm not sure how much the information is changing, but I know there's work to change it. First of all, I want to ask the healthcare professional shortage areas. How many counties in the Commonwealth of Kentucky of our 120 counties fall in that category?
It's going to it's going to be by provider type. So there's different HPSA scores for dental. There's different HPSA scores for mental health and providers. So that's the first designation that we want to talk about. So like I said, the mental health is all 120 as of this moment. Every single county is a mental health shortage area. If we go into dental and primary care, I don't know the exact number, so I don't want to misstate it, but we can get that information back to you.
Okay, please do, because by some of the numbers, it's as many as 118 to 119 of our counties here in the Commonwealth.
Yes.
And that doesn't really help our healthcare deserts very much at this particular time, because we're not forcing people to go out into those areas. Second question. When we are obtaining some of the information about why physicians are choosing to leave the Commonwealth of Kentucky, where is most of the information obtained? Is it obtained by talking to the leaders of the organizations? Is it learned just through studies? Is it learned by speaking to private practice physicians? I seldom hear anyone come in here and tell me about, I've talked to all the private practice physicians, the boots on the ground. Does that occur?
As far as I know, there's no data out there that says that. That would be a really interesting survey to do
Yes,
as they
ma'am.
leave.
Yes, ma'am. I agree 100%
Yeah,
it would.
and I think sometimes the entity that they work for, that when they leave, they do an exiting survey, but nobody sees that. So I don't know where the data would be.
If I may offer one suggestion, having been in the healthcare space for about 40 years now, I'm the old guy. Nobody asks us,
Yep.
and that's sad. We're
It
trying
is.
to solve a problem that involves us, but nobody asks us. That's interesting. But thank you very much.
I think that's a good point, because even with nurses when they leave, do we ask that question of why you're leaving the profession?
No.
Yep.
Thank you very much. Thank you, Madam Chair.
Thank you. Good questions. Senator Wise.
Thank you, Madam Chair. Thank you all for being here. I appreciate the presentation. I want to drill down on, no pun intended, on the dental portion of your presentation. Mobile dental clinics, how much of those are covered in the areas? I don't know if you got into that in your surveys and your research, that are covering portions of maybe far west Kentucky or parts of Appalachia? And if I could follow up with a second question, Medicaid. How many dental offices are seeing Medicaid that may have a dental practice in a county, but they do not see Medicaid?
I'll be happy to answer that the best I can. We do have some mobile dental folks in our eastern Kentucky part of the state. There's also some in the western part of the state. Most of that, I think, is preventative care, not then bring them into a fixed clinic to do the work. I can tell you that in eastern Kentucky, it's 3 months before you can get an appointment. Even if you have most of them are not taking any new Medicaid patients at all. They'll see the ones that they have, but they won't take a new one. So it is truly a burden with Medicaid for the kids that can't get in.
Have you had any discussions with the cabinet, and is it time on Medicaid reimbursement for the dental community? I don't think it's been since the 1980s that they've had an increase.
And that's what I'm told from the dentist when I call to say, hey, this
You're
kid really needs
100%
to
correct.
get in, and it doesn't reimburse me enough to even clean their teeth.
Have you had conversations then with the cabinet to ask, is it time that we take a serious look at reimbursement rates to hopefully help rural Kentucky and even urban areas with that?
I personally have not, but I would love to.
Perfect. Thank you so much.
Okay, thank you. We've got a lot of interest in this topic, as you can see, and we have quite a few more questions. I'm going to allow a few more, and then we've got a pretty full agenda. So, Representative Callaway.
Thank you, Madam Chair. Thank you for the presentation. Been very thorough, patient with us, so thank you for that. My two questions involve retention. So we're talking about 2 years required in the contract. Why just 2 years?
That is the federal guidelines that was set for loan repayment. Now, some of them are not there just 2 years. If they, like I said, but if they owe a lot of money, they can come back and reapply. And we can keep them 4 years.
So
it's
that's
according to what their debt is.
So that's federal. That comes federal.
Yes.
Okay. And then included in that retention topic, why are we not requiring tracking agreements, agreement to keep in touch so that we can do some kind of tracking on the data?
We do require it.
It's just not followed through.
No, if you're talking about once they leave the program is when we have trouble tracking them.
Well, that's what I mean.
Yeah.
That's a prerequisite. You will allow us to have some kind of contact or check-in, something that we can track for retention purposes.
I wish I could make them sign in blood that you will never leave, that I will always be able to track you.
Right.
But unfortunately, in the contract, when they're in the contract period,
I got you.
there are requirements that they do that. After they leave that contract period, they're no longer contracted to tell us.
I got you.
But I wish we could do that.
Sure. So the other thing is when we talk about applications and considering which clinics are eligible for the matching money, and also applications as far as individuals. What are we looking at? What are considerations that you're taking into account?
As far as the match that the clinic would have to pay.
Right, the clinic, and then individuals. What are we looking at for them? I mean, what kind of requirements are you looking at?
Okay, you want to take that one and I'll.
So first, the individuals are not paying. As long as they are continuing to pay their payment required by their loan. The only thing that we say is that they don't pay off completely, because then you get into this mess of we're sending them, $25,000 and they're at $23,000, and then there's an overpayment. So we are, when we take in those applications, we're ensuring that they're not getting an extra amount from our organizations. And then part of that is that they continue to be compliant with those loan providers. So over the past couple years where we've had no loan repayment required, that's been easier to track it, just because that's not been required for those providers. But this upcoming year now, this month, where that has started back, and that's part of the process of ensuring that the payments are being made from both sides. But the individual has no commitment to it for the loan repayment. It's for the federal side, the state loan repayment program. It is the agreement is really between the organization will provide the matching funds, and then our organization will provide the loan repayment. Does that
They
help?
do have to prove to us that those payments were made.
Yes.
Once it goes toward their state loan, they have to show us that it was paid.
Thank you, Madam Chair.
Okay, thank you. I'm going to ask members to keep their comments or questions short. Try to limit it to one question. Senator Tishner, please.
Okay. Hi, thank you so much for being here today. Can you explain what Delta is in the tracking? You have urban, rural, Appalachia, and Delta.
Okay, the Delta region is in the western part of the state.
Western. Okay, good.
Yes.
That's what I was suspecting, but I
Yes.
wasn't sure.
Yes.
Also, those who go into private practice outside of a health system like U of L, UK, Norton's, do they have an opportunity to have this loan repayment? Can they apply for that as well?
It is not.
Outside of, yes, as long as they're nonprofit.
Okay.
So that's the biggest, probably one of the biggest barriers. You have a lot of those independents that are for profit. And a lot of times when they call, that's the first question that we ask to try to help filter some of that out. We have plenty of clinics outside of that, outside of those systems, but they have to be nonprofit.
Okay, thank you.
Senator Berg.
Thank you. Thank you for the presentation. I just want to make two general comments for the committee. One, the majority of physicians end up staying where they do their residencies. So if we could fund more residency spots in this state, we could train more residents to become physicians, and the majority of those will stay in the states where they are trained. Right now, we're not doing any state-funded residency positions, as far as I'm aware, and that is an option for us. The second thing I want to say, and this is a warning, but I hail from University of Louisville School of Medicine, where I am still on staff, and I have spent several sessions now with our first and second year medical students at U of L, and almost without exception, these students tell me they will not be staying in the state of Kentucky to do their residencies, guys. I want you all to hear this because this is important. They feel that the healthcare environment in this state is overly restrictive, that they cannot get the training that they need adequately in this state, that they cannot serve their patients the way they want to, and they are not staying. I have had multiple discussions with this first and second year medical students at U of L, and this is their overwhelming sentiment. So as legislators, you all need to be aware that the decisions you make here that impact healthcare will be impacting the future of healthcare delivery in this state in a negative way. Thank you.
Thank you, Senator Berg. And on the GME slots, I'm working on that. We do have some state-funded slots. Yeah, we do. We're trying to expand that, and that's pulled down through Medicaid dollars. Those are typically funded through Medicare. We can do that through Medicaid, but let me just say it's complicated. So, as is this and all the braided funding that we talk about. Representative Fraser Gordon.
Thank you, Chair Lady. And actually, Senator Tishner asked the question I was going to ask about the nonprofit status. So wish it could be expanded in some way because there are a lot of providers working outside of nonprofit. Thank you.
Thank you. Yeah, is the nonprofit status, is that a federal guideline?
It is.
Okay. All right. Thank you. And then Representative Justice will be our final question.
Thank you, Madam Chair. And I want to record myself as president. I was
Oh, well, thank you. That was easy.
I want to touch on what Senator Weiss was talking about with dental, because I'm a dentist in Appalachia. And he mentioned the mobile clinics, and there's not enough mobile clinics in the world to service what we need. And Medicaid, as he said, it's been since the 80s. I think since I was born, 88, I think is the last time that it was messed with. So a dentist in the mountains, as I say, that if you're accepting Medicaid or you're falling under this status that you would have to, you're working with a 5% profit margin. So if you do $1,000 worth of work on your patients, you make $50. So if you have a post-operative complication or anything, even if it just takes a little longer, the procedure, than it should have, you end up paying money to see these patients. And just from a business standpoint, no matter how passionate you are about your community, you just can't do that. You can't survive. So that keeps most people from coming my way, from the get-go. So, and like the nonprofit status, I think, some of these private practitioners, my father's one of them. I know tons of them. They'll never fall under this status to get this assistance, even though they're helping the community more than most, and I think there should be some way that if you're in these underserved areas or your area checks these socioeconomic boxes, that you should still be able to get the assistance so you can stay in these areas and make a living and help. That's all. Thank you.
Thank you. All right. Thank you so much for this presentation, and thank you for all the interest, everyone. I'm enthused that everyone is so curious, and we do have some members who weren't here when we passed the bill to expand this. So, yeah, great information. Thank you. Keep up the good work. I would suggest reaching out to individuals' parents if you want to find them when they're moving out.
Good idea.
Senator Merritt, did you have one more comment?
Just very briefly, we've talked about this payment disparity a lot, but I think we have a tendency to overlook our urban healthcare deserts as well. In an attempt to address this, because we've talked about it for years, is Senate Joint Resolution 54 passed last year, asked the Medicaid Department to develop a payment methodology based on the National Deprivation Index, recognizing that the most deprived communities probably deserve some special attention. So I just encourage our committee members, that report is supposed to be released, I think, next month, to pay attention to that and see what we might be able to get out of that. I think it could go a long way towards helping address this. So thank you, Madam Chair.
Thank you. Excellent point. All right. Thank you so much. I'm sure we'll be in touch to talk about that state match. And
absolutely.
Yeah. All right.
Thank you for the opportunity.
Thank you. All right. Next, I'm going to skip around a little bit because we have our friends from UC Irvine, Dr. Robert McCarran, online, and I know that he got up very, very early to be with us today from the West Coast. And I think we've had so much interest in primary care and mental health. I think you're really going to enjoy this presentation. So I'd like to welcome Dr. McCarran. How are you, my friend? I see you up in the corner, so we're going to get you enlarged on our
Madam
screen.
Chair, good to see you, and thank you so much for the invite, and also glad to see all the committee members. Thank you for letting me meet with you for a brief time. I'm excited to talk with you, and hearing the presentation that just took place is, really something near and dear to my heart as an internist. Who also is a psychiatrist. And, we need to find ways in which we can better support our workforce and expand our workforce. And so a big part of what I want to talk about for the next few minutes is just that. And along the way, I'll be talking about recruitment and retention in the Commonwealth. We're also working with a lot of other states, including California, Tennessee, and potentially West Virginia, et cetera. So let me tell you a little bit about this program. But first, again, my name is Robert McCarran. I'm from the University of California, Irvine. I'm an internal medicine doc and also a psychiatrist, and do a lot of work in medical education as associate dean in the School of Medicine there, and also director of the Susan Samuel A. Integrative Health Institute. And I'm going to start out with the important stuff. What is the problem? And I'm going to focus nationally more than regionally, if that's okay. And just to kind of illustrate what many of you probably already know, we have a problem when it comes to behavioral health care in this country, and certainly in the Commonwealth. Bottom line is half of us in this country are going to be struggling with a psychiatric disorder in any given year 25% of us. For adolescents, it's not good. And again, this is just data from UCLA looking at 1 in 3 adolescents reporting serious psychological problems. You know, when we think about kiddos, we think about asthma, for example, and about 12 to 13% of kids up to age 17 will have asthma, reactive airway disease. About 50% in that same age group are going to struggle from behavioral health care issues, including depression, learning disabilities. Anxiety is a huge one. Substance use disorders. Suicide is the second leading cause of death among adolescents. Now, at the height of the pandemic, 40% of us were struggling with mental illness. We see that subsiding very little, even after the pandemic. Bottom line is it's affecting a lot of us. When it comes to drug use, over 100,000 Americans died just in 1 year alone during the height of the pandemic. And we see that's about 275 to 280 per day, which was a 30% increase from 2019 to 2020. Huge problem, as we all know, I think already in the Commonwealth and surrounding regions, also in California, and unfortunately disproportionate in this country relative to other areas of the world. Now, we saw this with primary care providers. We saw this with primary care docs just now, right? But I will say, with psychiatrists and the workforce in behavioral health, there's a huge problem, right? And so if we look at just the workforce alone, about half of all psychiatrists nationwide, and certainly in the Commonwealth, are looking towards retirement, right? They're in that stage. And as Madam Chair mentioned, I can tell you in my career and probably in my lifetime, and I'm not that old, but I'm kind of old, but I will tell you this, it's unlikely that we're going to have enough spots for residency and fellowship, particularly in primary care and particularly in psychiatry. There's a lot of reasons for that. It's complex, but it's unlikely to happen. And so what I'm talking to you a little bit about today is how do we concretely and demonstrably expand the behavioral health and psychiatric workforce. So as we see it now, about 60% of people struggling nationwide are just not getting the care. So they're struggling with depression, thoughts of suicide, substance use. 1 in 3 in our lifetime will be struggling with some type of substance use disorders, usually alcohol. So about 60% aren't receiving treatment. For those who are receiving treatment, the majority of them are not getting it from behavioral health care providers, those who've trained in this area. They're getting it from those in the general medical setting. So emergency room doctors, OB-GYN, pediatricians, family medicine, internal medicine, nurse practitioners, and PAs. Bottom line is primary care is indeed the de facto mental health care delivery source in this country and in the Commonwealth. It's not a psychiatrist's office. It's not a psychologist's office or a social work's office. On any given day, about 40% of primary care patients, and it's a little bit higher in FQHC and underserved county settings, have a significant primary and active ongoing psychiatric issue, about 40%. It's a huge number. Unfortunately, 2/3 of primary care providers are not able to refer patients to mental health specialists. And when they do refer, about only 50% will end up seeing someone within a reasonable amount of time. So again, my apologies for sounding so dire here early in the morning, but it's important to point out depression is widely prevalent. Depression is the #1 cause of disability worldwide and in the United States. Suicide rates have increased significantly. And here's the problem. Over 80% of antidepressants are prescribed by non-psychiatrists, by primary care providers, but in that same setting, a huge chunk of those patients are not even accurately diagnosed with major depressive disorder. And here's why. The training is limited. So when you or a family member, a friend or neighbor goes to see a pediatrician or goes to see an internal medicine doc in primary care, family medicine in primary care, you should know that it's very likely they did not receive the right training, the right amount of training to really diagnose accurately, and treat these conditions. I'll give you an example. As an internist, like myself, we go through 3 years of intensive training. Now, I hate to say it, but when I was training in residency, I worked about 130 to 140 hours, and all of my colleagues did. It just so happens that the day I graduated was the last day of those work hours. The next day, the following day, we instituted nationwide an 80-hour work week, right? 80-hour work week. And that started in 2003. So we do have an 80-hour work week. Folks are working hard, though. They're working hard, and they're learning about the heart and the kidney and the liver, and they're providing care in underserved hospitals. So in 3 years of training as an internist, there's actually 0 minutes, 0 hours required for timed requirement in learning about clinical psychiatry or doing a clinical psychiatry rotation or experience. Now, there may be some lectures and things to that effect, but in terms of being in the trenches, in terms of working and learning behavioral health and psychiatry, 0 minutes required by the American Board of Internal Medicine. That's not good. We are working to change that. I do a lot of work with ACGME, which is the national entity that provides oversight to all residencies and fellowships. And the 15, 20-year goal is to slowly change this over time. Now, this is just data from California. I don't want you to focus in on that. What I would like for you to see is this. There's only 1 in 4 psychiatrists in this state that actually provide care in a safety net population. Just 1 in 4. About 50% of psychiatrists nationwide take cash only. And so the bottom line is, I know, and I've learned this over the years, and I've seen this firsthand as an internist who works in primary care in underserved county settings, there is a need to expand and optimize care when it comes to behavioral health care delivery. And so the University of California, Irvine, in collaboration and partnership with over 50 faculty nationwide, what we've done is we've created a program called the Train New Trainers Primary Care Psychiatry Fellowship, with an emphasis on training how to do targeted psychiatric care in the primary care setting, but also training our learners how to train regionally, so they can take this information and teach others. We also have a fellowship in the Train New Trainers Child and Adolescent Psychiatry, and also our inaugural class started in March for our Train New Trainers Primary Care Training and Education in Addiction Medicine, or TNT-PC team. And again, these programs are nationwide. This is just an overview of our faculty putting together what is probably the authoritative textbook, medical textbook on psychiatry for non-psychiatrists. On the flip side, we also recognize the importance of knowing that those with severe psychiatric illness, like schizophrenia, for example, and refractory and severe depression, die 20 to 30 years earlier relative to the general patient population. So a lot of our focus vis-a-vis this textbook through the American Psychiatric Association is to focus on general medical issues as it relates to those suffering with psychiatric disorders. Now, the Train New Trainers Primary Care Psychiatry Fellowships really focuses on what we call primary care psychiatry. How do you do a targeted exam? The thing I hear the most from my colleagues is, I don't have time for that. I don't have time. I got to deal with hypertension. I got to deal with the COPD. I got to deal with the substance use. If we don't deal with the depression, if we don't deal with anxiety, if we don't deal with the substance use, it's going to be hard to treat the diabetes. It's going to be hard to treat the hypertension, the obesity. It's going to be difficult to treat the arthritis effectively. Over the years, this is something that's very clear. We see that diabetes is commingled with depression, right? As an example, can't separate the two. And so we really focus in on how to not talk about Sigmund Freud and the intricacies of psychotherapy, but how does a primary care provider in rural Kentucky diagnose effectively and relatively quickly, and then initiate treatment and even serve as a bridge before they need to see a psychiatrist. We train on how to manage mild and moderate illness in that primary care setting, and do it in a way in which the primary care provider feels more comfortable. They have more knowledge in this area. They're going to feel more comfortable. And as I said, we train them how to train other folks. We also believe in, when we train, to look at outcomes. We don't believe it's we should just be saying, hey, here's a class for a year and good luck to you. In fact, we do two things. We follow these folks over time, and we make sure that our learning changes practice patterns, which we'll talk about in a minute or so. And that's important for us. The second thing we do is we don't stop after 1 year of training. We continue at no additional cost for the course of the career for all of our learners, now over 1,000 alumni. We continue to train them and mentor them on a very regular basis, on a monthly basis, and we invite them to continue with learning. We know that long-term learning is going to be sustained learning that results in changes in practice patterns. Now, the program, in a nutshell, looks like this: 2 intensive weekends. The first is usually in January, the second is in August. And these intensive weekends include our faculty, most of whom, and this is the important part, are primary care providers. So they're internists like myself, family medicine, pediatricians, but they're also psychiatrists. They're duly trained in both areas. And that's important because these teachers and mentors know what it's like to be in the front lines, as primary care providers, but they are also specialists in psychiatry. We also have a few times a month, usually again during non-clinic hours. We're training during non-clinic hours, so none of these learners are going to be leaving their day jobs, I can tell you. In fact, it's a great recruitment and retention tool. The County of Alameda, where Oakland is struggling with keeping and recruiting psychiatrists, and primary care providers. So what they did is they said, listen, we will pay the tuition, which is $12,500 really for the course of your career, but we want you to sign on with us. And if you're already with us, we want to make this a contingency for you to continue with us. And it's an investment into your regional docs. Now, in addition to what I've mentioned, we also have at least 1 hour per month of mentorship with those 50 faculty who are duly trained or multi-trained, and additional mentorship if wanted or needed, additional extra open office hours in specialty primary care settings, and as I mentioned earlier, career-long learning for all of our T&T alumni. Upon completion, our learners get a certificate from the University of California School of Medicine. These are just some of the topics that we cover. Note, child adolescent psychiatry. We actually spend about 20% talking about pain medicine and pain psychiatry. They're very much interrelated, collaborative care, etc. This is our staff. This is our administrative staff, now 8 strong full-time, based in the University of California. These are our faculty. And just to give you a perspective, our associate director, Dr. Gagliardi, is an internist psychiatrist at Duke, associate dean in medical education. We have folks from University of Cincinnati leading our child and adolescent psychiatry, also from Emory, leading our substance use disorders. So again, from all over the country, but specifically faculty who have that expert and unique training as duly trained docs. This is our research team. I'll talk a little bit about our research. I think it's important because we don't want to just have a program that says, hey, we're teaching stuff. We want to make sure that there are demonstrable changes in practice patterns. And of course, most important, this is our class from a couple of years ago. We have a close partnership with Cedars-Sinai in California, as well as other medical centers. And in fact, we had this meeting here at Cedars-Sinai. An overview of where we've come and where we're going with our number of fellows. And this is just one of the fellowship programs. We look to be at about 280 learners for our trainers primary care psychiatry fellowship. We'd love to have some learners from the Commonwealth of Kentucky. Where do our learners come from? All over the place. We did receive, just last calendar year alone, about $28 million from the state of California to provide this training in designated underserved areas to primary care providers, including emergency medicine doctors, OB-GYN as well. So there's a higher concentration in California, but like I said, we are sort of all over the map. We're able to do this because of partnerships. We can't do it alone. The University of California can't do this alone. I can't do this alone. We have partnerships that make this work. We partner with health plans, large health plans, in California and throughout the country, other academic institutions, as I mentioned, other counties, other states, and even other countries, looking at a dire need of psychiatric care in United Arab Emirates, for example. 86% of our fellows come from designated underserved areas. We want to keep that going and even increase that number. If we were able to train those in the Commonwealth, we would want 100% coming from designated, really very underserved areas and rural areas. Now, as I mentioned before, can't just do this program and say, hey, this is cool, right? We want to make sure that we are showing changes in actual ways that docs are practicing. So this is a paper we published just a year and a half ago looking at some of the demographics. Most of our learners are family medicine, internal medicine, but we also train NPs and PAs who are in the primary care setting. We measure pre and post fellowship self-efficacy, which also goes along to wellness and retention, and noticed a statistically significant improvement in provider self-efficacy, as well as pre and mid and post assessment of knowledge in general primary care psychiatry, where we saw statistical significant improvements during the course and at the end. We also were looking at the confidence in completing a psychiatric interview, which can be daunting in a very busy primary care practice. And also we looked at the ability to teach psychiatric topics. Both of these areas showed a significant increase, statistically increase during the course and after the training. This is a more granular look at confidence in managing, a self-report confidence in managing psychiatric conditions, looking at anxiety, substance use disorders, psychotic disorders, chronic pain, etc., and finding consistent increase in confidence and knowledge in these areas. We recently published a paper here just back in July looking at antidepressant prescription patterns among those who went through this trainers program when compared to those who did not go through a program. And we were able to partner with Inland Empire Health Plan, a large health plan in California, and looking at this EMR data. And what we found in a nutshell was interesting. We found basically that our learners are able to more readily recognize depression, again, the number one cause of disability in this country, and prescribe antidepressants more readily relative to those who didn't go through our program. And so we're really excited to see this. I will also point out, and this is something I'm really excited to talk to you about, we just submitted for publication 3 weeks ago, and looks like we have provisional approval on this publication in a peer-reviewed medical journal looking at opioid prescribing patterns among those who went through our program. Again, use of opioids for the treatment of chronic pain. And what we found is those who went through our program prescribed significantly less opioids for chronic pain when compared to those who did not go through the trainers program. Really exciting to see that. I know that you have a lot of stuff on your agenda today, so I just wanted to give you a quick overview on this. Again, presenting the problem that I think all states are seeing throughout the country, and then looking at a solution that can expand access to care, also help with recruitment and retention, even in the primary care setting. Again, I want to thank you for your time.
Thank you so much, Dr. McCarron. It's great to hear from you, and I don't know if all psychiatrists have a late night FM radio voice, but you are so calm, and actually my son, who's a psychiatrist, I think has been accused of falling into that category, so it must be part of the training. But anyway, I just wanted to say, substance use disorders and mental health issues here in Kentucky are no surprise. I mean, we all are very well aware of our issue, and I can't agree more that primary care physicians are the frontline defense when it comes to treating individuals when they first present with a mental health issue. So I think this is an exciting program. I had the great honor of traveling to San Diego to attend the Train New Trainer program, and I had a front row seat to very, very professional cohorts and discussions and presentations, and I can't tell you how impressed I was with the whole program. I think it makes a lot of sense to train our primary care docs. They're, like you said, they're on the ground with all these folks. And incidentally, I just want to reiterate something that you said. Our primary care docs and all physicians are capped at an 80-hour work week. So everyone kind of think about that. And the work and the demands of that profession. So anything we can do to better prepare individuals and get treatment to our Kentucky citizens, I think we need to do it. I will also point out that in the last budget, we had a line item that identified this program for a pilot project. Can you talk a little bit about where you are on that? And I know that we're working with CPE right now, the Council on Post-Secondary Education, to try to bring this program to Kentucky. There was no appropriation. Is that a stumbling block, or are we having some contractual issues?
Well, I'm hopeful that the contractual issues will move forward. We're looking to try and start with just 6 primary care providers, that we're able to train. And University of California, Irvine would provide scholarships for 2 additional, so a total of 8 as a pilot. It looks good. Things look like they're moving forward, potentially for a January start date for that first cohort.
That's very exciting. So,
yeah.
Well, thank you. Thank you for bringing this program to us, for educating about the program, and we certainly want to expand this level of training to primary care docs who are interested in participating. We do have one question, Senator Funke Frohmeyer.
Yeah, thank you, Dr. McCarron. I love this offering. It's so effective and efficient for professionals to be able to get that advanced training in such a good way. One recognition in Kentucky and the Commonwealth, we do such a great job with offering everyone access to excellent nutrition. But what I didn't see is that we truly do know that food is medicine. But I didn't see it as one of the offerings of how food can help with your mental, your emotional, your physical, just all of those additional problems that when you medicate with food, you may create significant problems.
Well, I have to put my other hat on, right? So I'm the Director of Education for the Susan Samueli Integrative Health Institute. So I'm the choir, and you're speaking to the choir here. You can see the last, I emphasized in red, a big focus is on provider wellness, which I think helps with recruitment, but also integrative health. And so mindfulness, food as medicine, nutrition, things that I think are important to cover, and we do that in this fellowship as well.
That's so great. That looks like far too small of a space for nutrition, because to me it's about 90% of the problems that we're having.
Yeah. Thank you so much.
Okay, well, that's all we've got, and I really appreciate your time. I will give you back the rest of your day, but thank you so much for joining us today, and I look forward to continuing our work.
Thank you so much. Have a good day.
Thank you.
Bye-bye.
Okay. Next, we are going to hear from Sarah Jo Best and Scott Lockard on the Public Health Department Transformation Update. And I know that you know the rules here. Just identify yourself for the record and proceed. And if you could just give a little bit of background about where we started with this, and I'm sure that's part of your presentation. Thank you.
Good morning. My name is Sarah Jo Best. I'm the president for the Kentucky Health Departments Association, which we refer to as CADA. I'm also the public health director for Lincoln Trail District Health Department.
Good morning, and thank you for having us, Chairs Mosier and Meredith, and Senator Elkins. Good to see you again. Scott Lockard, Public Health Director, Kentucky River District Health Department, serving Perry, Knott, Letcher, Leslie, Wolfley, and Owsley counties in eastern Kentucky, and co-chair of the Advocacy Committee for CADA. Thank you.
So we're excited to be here with you today. Thank you for the opportunity. We really want to share the accomplishments resulting from the work of the legislature and how that plays out and translates at the local health department level. The Kentucky Health Department Association, or CADA, is a statewide membership organization that exists to help strengthen Kentucky's public health system and local health departments. CADA represents 100% of the Commonwealth's 61 local health departments across our 120 counties, and we focus on 3 core focus areas: leading and advancing public health policy and advocacy, nurturing and enhancing statewide collaboration, and supporting leadership development and capacity building. Many of the leaders from your local health departments are with us today. Just want to raise your hand in support of the work that's been done for public health transformation. This is a summary slide about public health transformation because this initiative started around 2019, was enacted in 2020, and it shows where the legislation happened, where these statutes are located, and what they pertain to. Public health transformation really resulted out of some goals, which were to restore the fiscal stability of the current public health system, to introduce a modern, simplified, and focused public health model with clearly defined priorities, based on FAB, or Public Health Accreditation's Public Health Services and Public Health 3.0 principles, to create accountability at all levels within the system, to improve leadership capacity, and to prevent duplication of effort, reduce waste and red tape internally and externally, and support and emphasize data-driven decisions. And so what this did is it assures a minimum package of services across health departments in all 120 counties. It prioritizes those services as well. And so when we look at foundational public health services, those are statutorily required. All local health departments, regardless of where they're located in the Commonwealth of Kentucky, provide these services to their jurisdictions. The core public health services are available in all 120 counties, and they are either provided directly by the local health department, or the local health department will contract with an entity to assure that those are available to those that they serve. And then our local health priorities allows for local health departments to assess their communities and identify particular needs of that jurisdiction. And then after we make sure that we do the foundational services, we ensure that core public health services are delivered, then we can also put resources into local health priorities identified that may be unique to our communities. So, Representative Mosier, I think that this speaks to what you were requesting, the progress of what has happened. And so this slide really is to demonstrate the commitment at both the local and the state level to not only advocate for, but also to implement the requirements of public health transformation. It also shows the improvement in the culture of the public health system as a whole. This legislation and these activities has no doubt contributed to increased collaboration and communication from local health department to local health department, but also between the local health department and the State Department for Public Health. As you can see in some of these initiatives, it's increased collaboration, it's improved our planning, and it's also aligned our strategies. One of the things that we talked about as part of public health transformation, and I brought up the three-legged stool because that's how we referred to it when we were in the planning process. We were looking at not only focused services, which I just went over, we'll talk about equitable funding, but also stabilizing the pension obligation. And so that happened through House Bill 8. The instability of the pension obligation to our budgets each year significantly affected the local health department's ability to maintain our staffing levels. And you can see in this slide how that dramatically decreased by over 50% from 2008 to 2020. This was not only problematic for the local health departments, but overall for KERS, as it decreased the number of employees contributing to the system. It really truly was the only variable that we could control, was the number of staff that we had. The passage of that legislation, the House Bill 8, to change the way that we pay the liability within the pension system, as well as the subsidy designated for local health departments, has significantly improved our ability to hire staff at normalized cost and increase our capacity for public health response, as well as being local employers within our communities. So for some rural communities, your local health department is a core provider of employment. In 2022, the local and state health department representatives conducted a review of local and health department merit employee classifications and were able to adjust the minimum and mid salaries in order that had not been done since the early 1990s in order to also retain staffing levels. You can see that there is a gap in data from 2020 to 2023. We were not tracking. We weren't tracking the data as well during that time period. We were busy. But another thing that happened with there is the numbers look a little odd. If you'll remember, we did bring in a lot of temporary and contractual staff to respond to the pandemic. So the numbers that you see in 2023 are more accurate than what we would have been able to derive during that midsection. The other thing that I want to talk about with staffing is, remember I mentioned the prioritization of services, with those foundational being our first priority, those core being a do or ensure, and then local health priorities in that third category where those are unique to each one of the local health departments. Prior to public health transformation, we were really flipped the other way. We were doing a lot differently across the Commonwealth, and we were focusing a lot of our resources not within the statutory requirements, but in those local specific programs. One of the things that I want to show you in this slide is really how that has changed. So when public health transformation came about and it prioritized our staffing levels, we saw a shift in the way that we staffed our local health departments that aligns with public health transformation, where we were transitioning more staff or we were hiring more staff to assure those foundational and those core services. The number that you see under hands is really telling, and I want to go over that just a little bit. The transition of staffing also that happened with House Bill 8 is that we had a lot of contractual employees that we were trying to not pay pension on, to be quite honest with you. And one of the things that came out of that is we transitioned some of those employees back into the merit system or into the system where we pay pension on them. So you'll see an increase of staffing. You also will note that some of our positions were part-time. If we kept them at a certain number of hours, then we weren't required to pay into the pension system. And so we may have needed them to be full-time, but it was a way to control cost. And so some of those employees are now full-time employees. They're contributing into the pension system. We have moved away from those contract entities and are hiring people within the local health department. I wanted to give an example of staffing, too, for the Powell County Health Department. This came out in one of our surveys where we were talking about the local impact of public health transformation. The Powell County Health Department furloughed employees every Friday for 9 years. After public health transformation, they are now able to be open 5 days a week with extended hours on Monday. They have increased their staffing by 60%, and which is not much. That's only 5 full-time employees to 9 full-time employees. And while this may seem small in numbers, the additional nurses enable them to be more robust and respond to situations that may arise. And those additional hours on Monday make us more accessible to people that may be working as well. So I just want to note that the staffing is not due to inefficiencies. Rather, many local health departments were not able to maintain adequate staffing levels to assure that we met the statutory responsibilities. And while we have seen increases in staffing, we are not likely to achieve the numbers in 2008 as we are more defined and focused. But the transition has definitely is started paying off. In hands, we're also seeing an increase in services as a result of that increase in staffing. So another thing that I would note in the HANDS program is that in the past, we were unable to pull down all the federal funds that are in that program because we couldn't staff adequately to be able to provide the services to get reimbursed for the services. And so this will allow us to pull down more federal funding.
Sergio, could I just have you explain what the HANDS program is
Sure.
for those members who might not know?
Sure. So our HANDS program is a strengthening families program where we work with families on health, access, nutrition, nurturing, and development. And it has wonderful outcomes. It is research and evidence-based, proven effective program, and members can self-refer into it. Many of us offer this availability within our websites and things like that. But it's available to either pregnant mothers or mothers of children up to the age of 90 days.
HANDS really promotes positive parent-child interaction. We go right into the homes, do home visits. We engage the moms and dads prenatally, if possibly, and it is an evidence-based program that is nationally acclaimed for the impact it has on our newborns.
And it's federally funded.
It has multiple sources of
Okay.
funding. So there's some federal funding, there's the ability to bill Medicaid for those services, and then there's also some state funding.
Okay, thank you for that clarification.
Okay, public health transformation, really the timing could not have been better for us in local health.
Do you mind pulling your
departments.
microphone a little closer?
Sorry, yes.
Thank you.
Okay. Public health transformation was very timely for all of us. As we saw, as we look back here, 2020, of course, the pandemic happened, and luckily that public health emergency has just recently been declared over. But we had a lot of other issues going on during this time period as well. In March 2021, we had what was called a 100-year flood, major flooding in eastern Kentucky where the three forks of the Kentucky River merged. Record flooding there. Betaville, they hadn't seen flooding, since 1957 of that scope. Then later on in that year, December of 2021, we had the Western Kentucky tornadoes. Your health departments have all been responding on the front lines of these disasters. The flooding of that year there impacted my health department personally, the Lee County Health Department. We had just got our first shipment of COVID vaccine. We actually did a boat rescue of vaccine so that we would not lose it when our generator went underwater. We went in a John boat to save that vaccine. We did whatever it took. The same thing happened later that year when the tornadoes ravaged Western Kentucky. We had public health directors and staff who their own homes were impacted, their own families were impacted, yet they were helping do triage at the candle factory. They were going to the nursing home where their own daughter worked, not knowing what the conditions were, whether their own family was safe or not. But they helped, bring together people, in Graves County out there during that tornado event. They served as a base of operations because the health department was not impacted and could operate as such. Then in July of 2022, we got the 1,000-year flood in eastern Kentucky. We had flooding that had never been seen before. The record, the river crested in downtown Whitesburg at previous crest had been 19 feet. It crested at 23 feet. I lost a health department annex building completely, 8 feet of water in that building. Our main health department, we had flooding on the first floor of that. We had multiple loss of life throughout eastern Kentucky. This picture depicts how we responded. Our public health staff, I could never be more proud of our public health staff, what we've done, and public health transformation has played a big part in this. The one-time funding we got from some of the COVID funding, and then the stabilization through our PHT funding has helped us to be able to have that capacity to be there when our communities need us. When your constituents need us, we're there. I never thought we'd be literally rolling up our sleeves. We talk about rolling up our sleeves and providing services outside the walls of the health department. Well, I had a health department we couldn't use for over a month. actually almost 2 months. We provided services off the front porch. We got in the four-wheelers. We went up creeks. We went up hollers in eastern Kentucky. We went where the people needed us. We gave vaccinations. We actually helped in some situations with trying to locate families. And we moved a nursing home. Our community, the Nim Henson Nursing Center in Breathitt County, the dam was in danger of flooding. We moved an entire nursing home in 8 hours overnight to the Wolfe County Middle School. And your public health staff was on the front lines of that move. We were making sure that those people had what they need. I went and raided every supply I had in my home health agencies to make sure those patients had what they needed when we relocated that nursing home, and we did what was there. Again, thank you for your support. Without the public health transformation funding and support, a lot of this would not have been possible. When our communities needed us at their most desperate hours, we would not have been able to answer the call. But we were, because you all gave us that bipartisan support, which has truly made a huge impact on all of our health departments. We're also, using data-driven decision-making. This is what we want to do, is make sure that we're using data. We're not doing programs now because they feel good. We're using data. We're doing these community health assessments and community health improvement plans for our communities. We're bringing all of our community partners together. We're assessing what are the challenges and opportunities in our community, and we're convening groups to work on those issues. The data shows that 78.7% of local health departments had completed a community needs assessment, community health assessment in the last 5 years. 21% have not completed them, but they're working on them. My health department, again, is an example of a health department that is in progress. When I took over as the director of that health department, they had not done a community needs assessment. We were in the midst of doing one, and the pandemic hit, and then the floods hit, so everything was put on hold. Now we're back on track, and we'll have that community health assessment done by the end of this year. The assessments reveal what are our local health priorities. Adult health, there's a lot of issues. We've talked about access in the first part of this meeting. There's still a lot of access issues, a lot of issues with our PEDS patients out there, public health services for them, chronic disease management, diabetes, hypertension, just all these different things there. And then health equity. We have pockets, be it rural, urban. There are areas where there are major inequities for services and access and other things that we are looking at there. Cancer control and screening. We have a huge cancer burden, especially in eastern Kentucky and other parts of our state that we're working on with smoking-related illness and so on, that we do a lot. And then women's health issues. Now more than ever, it's so important that we make sure our women get the health care services that we need. Many health departments, again, like mine, are still offering family planning services, because when you have a young lady who is seeking to get reproductive health services, she may not want to go to the doctor where her medical home is all the time, and we want to provide her a safe environment where she can access the services to prevent unwanted pregnancies and take those responsible steps, not only unwanted pregnancies, but the spread of STDs and other communicable disease. So we do a lot of education. So again, the public health transformation dollars is helping us to do these community needs assessments, to determine what our communities need, and not let the tail wag the dog. Used to, we would do a program if there was some money attached. Well, that was always our first question. How do we get paid for it? Was it some Medicaid money? What was it here? But now we look at what our community needs, and we can. The PHT dollars has really given us a little bit of flexibility where we can do what a health department is supposed to do. One of the big things that we've been able to do too is to invest in our infrastructure. Health departments have been neglected for many, many years because we were on shoestring budgets. We didn't have adequate staffing, much less could we invest in computer upgrades, phone system upgrades. My health department had computer speeds of 4 megabytes, okay? 4 meg. Our main activity was watching the wheel go round and round on our computers when we were trying to do stuff. Now we have 1 gig in each health department, up and down. We can now realistically look at electronic health records. We can now be more efficient and do computer environmental health systems to better serve our the development partners out there when they're coming in to get their permits for their restaurants, their grocery stores. So we're much more efficient. We had buildings that were in major states of disrepair. We've been able to put new roofs on, put new windows in, do many different things there to our buildings. Vehicles, some of us, if we had vehicles, we were buying them here at surplus, and we were buying worn out state police cruisers and used them for our home visitors to go up hollers in. Now we've been able to invest. We were able to invest, many of us, in environmental health vehicles, which again were utilized in disaster response, being able to move assets throughout a district. My district covers 2,000 square miles. So if I had the assets in Wolfe County and Campton, but I needed them in Whitesburg, I was begging and borrowing or using my personal Silverado to move these assets. Now we have that capability. We don't want the number one requirement for a public health director in Kentucky River be if you own a truck or not. We want to be able to have that capacity there at the health department so we can do those things. And again, just we have seen just investment in our infrastructure. It has been huge for us as well. It is really nice. I'm starting my 34th year of practice in public health. And on the national level, because of this bipartisan efforts that we have seen, we are getting requests all the time now for this Commonwealth of Kentucky to talk about how we did things, how we worked across the aisle, how we worked with our partners to do what we have accomplished in our local health departments. I was never more proud than our recent NACHO conference, which was held out in Denver, Colorado, where our president, Sarah Jo, and then our state health commissioner, Dr. Stephen Stack, was asked to be on the opening plenary session about working together, partnerships between local health departments and state health departments to serve the people, not putting politics first, but putting the people first. And we have received great accolades for that. Other presentations were done out there at that by many of our different public health directors at that conference. Again, Kentucky is being looked at for the first time in many years as a leader in public health. We're not ranked last. We're really looked at as being in the top echelon of public health services across the nation. And for somebody that's been here for 34 years, that feels great. It feels really good that I can be proud of what we're doing. I've always been proud of what we're doing, but to see that we're recognized, to see that we're doing it right, and to see that we're all working together to make this happen. Columbia University identified 5 states in a journal-reviewed article that are models and examples, and came and did interviews with our public health directors and published this. So again, example after example. We presented at the National Harm Reduction Conference about substance use disorder services, Kentucky being seen as a leader in the nation on preventing overdose, harm reduction services. I had people from California coming up to me after the presentation and say, "How are you doing this in Eastern Kentucky?" I said, "It's because we've got a lot of common sense people that recognize the problem and we make it work. We work together. We identify the problem and we're going to find a solution together." So again, just it is so good, and rightly so. Dr. Stack was looking to Sarah Jo here. I'm an advocate for the locals here. Local leads the way, but it's that partnership. Our partnership has really been strong, and we're very grateful for where we stand with that. So, where do we stand today? As we always, and as we lead up to a budgetary session, the most important piece of legislation passed is going to be our budget. Public health transformation, there's a formula that's included in 211-186 that we utilize. We realized when this formula was passed that costs would go up each year, and so this formula takes into account that. So, that this funding for public health transformation, it prioritizes foundational public health. It's based on our population that we serve. It requires a certain number of FTEs dedicated to provide these services, and it requires the minimum ad valorem tax, which is set by the commissioner by statute there at 0.018 cents per $100 of assessed value. Over the next biennium, our local health departments will put in $155 million of local tax money in addition to the state general fund dollars and all the federal grants and so on that we bring down as well. It's based on an average cost of salary, benefits, and operating expenses associated with the foundational services, and so these numbers are set as we lead up to the budget. For FY 2025 and 26, and I'll walk you through this, the first column on this, that Public Health Transformation Foundational General Support, this excludes the pension subsidies, and this is the amount that formula reveals that we'll need to fully fund public health transformation funding again, $22,995,77 in FY 25, and in 26, $24,979,275. Then the next column there is according to House Bill 8, they looked at the pension subsidy that was already being given to every quasi-entity and non-state employer there to support them with their pension costs based upon the fiscal year 1920 baseline. And so that amount remains constant. So that's at $25,169,402. And then the requested subsidy for pension liability per House Bill 8, this is the additional assistance that House Bill 8 lined out there for the quasis that would support us with that increase in costs based upon the new way the liability was being assessed. That liability, we had a different portion of that, and again, try to educate some of you that have never seen this before. All we used to talk about was pension, and so now, luckily, it's only a small part of what we talk about. But the pension costs there, these were going up dramatically, and so the House Bill 8 assigned out a portion of that liability to each quasi, each non-P1 agency, and the state. And we were given support with that because the legislature realized that we couldn't assume all those costs immediately. So this was in a step-down format, and it was supposed to step down 10% per year, that additional subsidy there. Well, in FY 23 and 24, because of the pandemic and everything else, that additional 10% step down was pushed back a year. So we got 100% funding in 23, and then in 24, we got 90% of those anticipated costs for that pension. So that's one of the things we need to discuss about where we're at, with going into the budget. According to the law there, the bill that was passed, we would actually be at a step down of 70 and 60 over the next 2 years, but because the initial was postponed, are we really going to be at 80 and 70? Our ask is that we stay at 100% funding because the locals all supported House Bill 8 because we agreed to share in the pain when there was cuts to the budget and we didn't have the funding. Now that we're running budget surpluses, if we shift this cost back to the local, the thought process was then that we could raise local taxes. So it's going to be a tax increase on your local constituents back home on their property taxes if we have to do that cost shift. So we're making the ask for 100% of that. It's a statewide problem, so let's handle it as on a global basis here and work together. And so that makes our total requested state funding of $81,024,579 for FY25 and $83,013,277 in fiscal year 26. Again, the gains that we have made in public health transformation are huge. We are seen now as leaders in the nation. Our trajectory is upward, and we're doing great things for your communities, our constituents, your constituents, and we want to keep all that up. So we appreciate your continued support of your local health departments. Thank you.
Wow. Well, thank you so much for this update. And I was very proud to sponsor House Bill 129 and work with so many great partners in making sure that we were able to just get back to those core and foundational services that the health department so aptly provides, and then really streamline some of the, streamline the services, put in a funding formula for staffing, which stabilized our staffing, and I think that we all see the benefits to our state in doing this in preparation for these public health emergencies, which obviously no one knew were coming. But that's the whole point in having a ready health department. So what we did worked, and it is working, and I agree wholeheartedly that we are seen across the nation as a leader in this area. I, too, have talked to the Columbia researchers, and I'm now part of the Millbank Memorial Fund Fellowship to talk about or to look at population health and system changes, which we all know we need to focus on in Kentucky. So I really appreciate the work that you've done. And then you got to the budget, and that's a little deflating. But, I mean, it's important, and we see that it's working. So I think we have a few questions. Representative Burke.
Thank you so much, Chairperson Mosier. And I want to thank you also for your leadership as it comes to public health. We wouldn't be making the progress we were without you, so I want to thank you in this forum for that. I also want to thank the presenters today. It's so encouraging to hear that Kentucky is leading in something that's so important. I want us to be leaders in everything, and so I'm going to ask you a hard question. As guns are now the leading cause of death for children, this is a public health crisis. What can we do in Kentucky to save the lives of children from gun violence?
Okay, thank you very much for that question. It is obviously a very complex issue. I'm an avid hunter and sportsman myself, and guns are part of our culture here in Kentucky. So we will do what public health has always done. We will, if we are tasked with this, we will bring together our community members. We will talk about the issues. We'll try to identify what is going on. We'll try to creatively think about solutions and find common paths that we can agree on to move forward together. There are no easy answers. As with a lot of public health issues, we deal with HIV, communicable disease. There's no easy answers for a lot of these things. But we need to bring together the impacted parties. We need to have intelligent conversations about those issues. And then we need to see what we can do to move forward together where we can find common ground and get as workable a solution as we can come up with.
Thank you so much. That was a true social worker answer, and I appreciate that as a fellow social worker. I think that there are really excellent solutions that the legislature needs to take up and to charge you with finding the data-driven solutions so that we aren't losing children. We can bring them up in Kentucky and allow them to be our next health leaders. So thank you so much.
One of the individuals I had great respect for, Dr. Gil Friedel, I know some of you remember Dr. Friedel at the Markey Cancer Center and his impact. He always said if the problem is in the community, the solution is in the community. We need to talk to our communities and see what they have to bring to the table. Oftentimes they have some great ideas and great solutions if somebody will just bother to ask them, and that's what we need to do. That's what we do in public health.
Thank you.
Thank you, Scott. We have Representative Bratcher.
Yes, thank you very much for the presentation. And Sarah Jo, thank you for all that you've done and the leadership you've done in our community. It was, and for the tour you gave me early on in the year, I appreciate that. I was very impressed with the amount of responsibility the health department has, the amount of area you have, and the limited staff and resources you have to take care of it. So I did want to encourage all the other legislators, if you haven't visited your health department, that it would really be an eye-opener, I think, for you if you haven't. So, but I did have a question for you. When I was there, we talked about a program that could be instituted across the counties and that was limiting because of some legislation. Do you recall what that was, and can you explain some of that to us?
The program that we discussed was the Harm Reduction Syringe Service Program. And the requirement in order for local health departments to provide that service in their community, they have to have approval from their Board of Health, but they also have to have approval from the county fiscal court in the county that they're wanting to operate, as well as the city council in the community that they're able to operate in. And so for my 6-county jurisdiction, we've been able to obtain that in 3 of 6 of our counties, but Hardin County in particular was the one that we were discussing that we had not been able to obtain that approval yet.
So what would you recommend? Would you recommend the law changing to allow that to happen without the approval of the county and city?
You know, as a public health person, and Scott just kind of alluded to this, and I was thinking about systems. Sometimes when we address things at the local level, and we do that through grassroots initiatives, it's more palatable for the local level for that to happen. Now, while that may require time and patience, which I've had to learn on the job skills for that, I've seen benefits of both. I can't answer it specifically because sometimes I think in communities, things that are homegrown work better because there's buy-in. That's what the community comes up with the solution. I think we'll get there in our local communities, but I would look at that a little bit deeper just to make sure that there aren't any unintended consequences. So I guess my answer to that is I'm not sure if that's the fix or not. I would have to look at that a little further, but I'm not completely opposed to local approval either.
Okay, thank you, Sarah Jones. Thank you, Chairwoman.
Of course, thank you. We have 2 more questions, and then we still have to review our regs real fast, and then we have one more quick presentation. So I'm going to allow Representative Rourke's.
Thank you, Chair. I just wanted to take this opportunity to ask a question that has been asked of me. So I wanted to see, had we ever explored allowing WIC benefits to be used on mobile delivery orders?
Yeah, that would be a federal issue. We'd have to talk to our federal providers about. One of the great things about WIC benefits and WIC access was during the pandemic, we went to virtual, telephone, online certification. Many of our counties had 100% participation rates. So we got more WIC benefits into the hands of individuals that needed them for their children than ever before. So we had a lot of lessons learned. So that's something too that I will be glad to take back to our partners at the state and address with our federal partners and see where they stand on that.
Thank you.
Thank you. And then we have Senator Tishner.
Thank you. Thank you guys for being here today. And I want to shout out to Matt Rhodes, the Oldham County Health Department Director. Is the Kentucky Department of Health Association still recommending local departments to offer the COVID vaccine to youth?
So those, for the most part, based on availability, we've transitioned how we obtain the vaccine, where we were obtaining it through the government, and now we're purchasing the vaccine. So that's shifted. But for health departments that want to offer that vaccine and obtain that, they're still able to do that.
As data is coming out, Pfizer just recently, I think it was last week or the week before, issued a statement that they see increased risk of myocarditis, especially in young males aged 12 to 17. How is the health department recommending informed consent at the local departments where they're still giving this vaccine out to those youth?
So the decision of whether to vaccinate or not is one that the parent makes with the primary care provider. Access to that can be at the local health department, it can be at a pharmacy, it can be within the pediatrician's office, but we would always advise the parent, and there's unique situations with each child, right, that the primary care provider would be more aware of. So we would always advise that decision be made by the parent in consultation with the primary care provider of the child.
Okay, but at the health department level, is informed consent given to those patients that come in to receive that vaccine, given the fact that we have new data that's stating there is a health risk for myocarditis?
So whenever we give a vaccine, we're required to give the information on the vaccine, which include the risk and benefit and information for that. And so those have recently been updated.
Okay, thank you. Thanks so much.
Okay, thank you so much for being here today. Really great presentation, and certainly appreciate all the work that you do for our citizens and across our state. Thank you all. Okay, next I would like to, because we have some members who need to scoot out to other committee meetings, I'd like to go ahead and consider the regs that are before us. Everyone received the links to those regs. Are there any questions? All right. Okay.
I was just concerned about, thank you, by the way. I was just concerned about the 055015. Moving that to a Schedule 1 controlled substance, the dangers associated with that. I'm new to this, so if you could explain to me why this is still on the market and available.
Yes,
and
absolutely.
Is it currently an OTC?
It is. This is a reg that we deferred last time so that I was able to meet with the cabinet and OIG on this issue. I had that very same question. I didn't know a lot about it, and we're talking about tianeptine. And this is apparently also known as gas station heroin. It is being sold in gas stations and convenience stores. It's available to anyone, kids included. It's in colorful packaging, and this is apparently not FDA approved. It's a very dangerous, drug. So we are in favor of going ahead and moving that to a Schedule 1 on a statewide level. So that's the background. Hopefully that helps. Do you have any other question?
Just concerned about the banning. What's the process?
Well, this is in regulation, and the enforcement would be through the cabinet. So we can look into that more closely if you'd like.
Sure, if we can make a recommendation, at least to start that process.
Okay.
Thank you.
All right, thank you. Okay, any other questions? Okay, are we all voice vote in favor of reviewing these regs, or saying these regs have been reviewed? Yes, thank you. I don't think we need a motion. Yeah. Okay, I do want to give Connor Rose a few minutes. We ran out of time at the end of the last meeting on PBM reform, and I wanted to give him a few minutes to talk about the role of the pharmacy benefit managers. So welcome, Connor. I'm sorry again that we are running late. Just go ahead and introduce yourself for the record and proceed, please.
All right. Thank you, Madam Chair, members of the committee. My name is Connor Rose. I'm a Senior Director of State Affairs at the Pharmaceutical Care Management Association. We're the national trade representing America's pharmacy benefit managers. I'm going to run through some slides. Got a few other comments outside of that. Happy to take any questions, and I will be as judicious with my time as possible.
Thank you.
So let's start from the beginning. What is a PBM? Simply put, the most simple definition is that PBMs administer the prescription drug portion of the healthcare benefit. And when you consider the ecosystem in which we operate, you have 70,000 pharmacies around the country, you have millions of prescribers, billions of claims to process, and thousands of different drugs, whether it's generic, brand, or specialty drugs. We are charged on behalf of plan sponsors, whether that be employers, state Medicaid program, state employee health plan, Kentucky teacher retirement system. We are charged with organizing that system on their behalf to, and their goal is, the iron triangle of healthcare: cost, access, and quality. And those plan sponsors are trying to balance that, and that's what we do on their behalf. So these are some of the services we provide those plan sponsors. Again, claims processing. Probably most notable you see in the news perhaps is negotiating rebates with drug manufacturers. We negotiate discounts with pharmacies. We manage formularies, which is the list of drugs that are covered. We employ pharmacy and therapeutics committees to evaluate efficacy of drugs. And when we can create competition among drug manufacturers for formulary placement, which significantly drives down the cost of specifically branded drugs. We work with plan sponsors to develop pharmacy networks. Some PBMs operate mail service pharmacies. Some operate specialty pharmacies. They perform drug utilization review and employ disease management and adherence initiatives around diabetes, statins for high cholesterol, et cetera. These are our member companies. I don't want to spend too much time here, but we often hear that you have the big 3 PBMs dominating the market. And while that may be true that 3 PBMs control about 85% of the market, our membership extends well beyond that. And to that end as well, the notion that the PBM marketplace is, I would say, incorrect. It's highly competitive. There are 73 PBMs operating nationally, with 6 coming on since 2021. You also have companies like GoodRx and Mark Cuban Cost Plus Drugs who are trying to disrupt that, which, more competition is all the better. Again, these are the clients who hire PBMs: private sector employers, public sector employers, commercial health carriers, government programs, again, Kentucky Medicaid program, state employee health plan, and then union Taft-Hartley plans as well. This is one thing I want to highlight quickly: the plan sponsor RFP process. Again, the PBM marketplace is highly competitive. Employers or plan sponsors will issue RFPs with what they are looking for out of their PBM. If one PBM is not willing to structure their benefit or contract in a certain way, there is another PBM who will jump on that opportunity. In short, I'm just trying to say there's a lid for every pot when it comes to PBMs and plan sponsors looking for one. Again, employers are overwhelmingly satisfied with their PBM. I'll let you all take a look at the slides. I know you have those. But in that same vein, I do want to highlight the letter from KTRS that was sent to the House Ways and Means Committee earlier this summer. The federal government's been looking at transparency around prescription drugs. Our federal team has been involved in some of those conversations. But I just want to highlight a few things in that letter. I think last meeting the question was asked whether PBMs provide any value, and I think Deputy Speaker Rohrbach, had a hard time coming up with an answer. There were some laughs, and that's all well and good. But I think the fact of the matter is, as it relates to KTRS, you have 2.3 million prescriptions that were filled under that plan. Without a PBM, they would have spent $452 million on prescription drugs. But because of the PBM negotiating rebates on their behalf, that was reduced by 50%. On top of that, their PBM negotiated an additional $54 million in rebates and also provided $22 million in savings because of the use and incentivizing of mail order pharmacy. And as a grandson of a retired teacher on that plan, I'm proud to stand behind the work that that company is doing on behalf of their plan and the beneficiaries. Last meeting, we heard about white bagging, and I believe the Hospital Association said that there is no value in white bagging policies. And again, I would respectfully disagree. White bagging policies were implemented as a reaction to the exorbitant markups that hospitals place on their drugs for clinician-administered drugs. These are this is a list of some of the drugs that are subject to white bagging. They treat cancer, MS, rheumatoid arthritis, even Botox, surprisingly, is one of the most commonly white bag drugs used for migraines. But again, so this research is coming from AHIP. You may scoff at it because it's potentially biased, but there's plenty of other research pointing to the fact that hospitals significantly mark up the price of their drugs. A Moran report in 2021 found that hospitals charge between 234% to 724% of what they paid for medications, averaging 500% or more. And then even more respectable source, JAMA, the Journal of American Medical Association, an analysis of hospital-administered cancer therapy drugs, a median markup ranged from 120 to 630%. And those markups fall on the back of employers and other plan sponsors providing benefits in the Commonwealth. I also want to delineate the fact that it was said these specialty drugs, when coming from a specialty pharmacy, this isn't just your typical retail pharmacy with a counter and pills behind the counter. These pharmacies are accredited by national independent organizations, and they demonstrate a higher level of care and expertise than a typical brick and mortar pharmacy. They follow the Federal Drug Supply Chain Security Act. They are following the same protocols and procedures as hospital pharmacies, and they are in communication with the hospital pharmacies to make sure that there are no delays, that the dosage is right, and that the package arrives, and the integrity of the drug remains intact. I do want to point to a case study. I'm happy to share this with the committee from the state of Indiana. Purdue University carved out one drug and implemented a white bagging policy for that drug and saved $179,000. They said, great, all right, let's try some more. In the first quarter of 2021, they saved $2.5 million due to white bagging policies. So again, I would respectfully disagree that there is no value to some of these policies. Anyway, that's all I have. I do want to make a couple more comments. One of them being, we heard at the last meeting, Deputy Speaker Rohrbach mentioned that they're seeing great things in West Virginia as a result of passing some legislation regulating PBMs and regulating employer-sponsored healthcare and pharmacy benefits. I would respectfully disagree. We have not seen any data from the state pointing to less healthcare spending. I will say that that legislation mandated a reimbursement floor for prescription drugs and added a $10 dispensing fee to every prescription filled in the state. Reason would dictate to me that adding a fee to every prescription in the state on top of the other restrictions contained within that bill would not lead to lower healthcare spending. I would also point out that much of what is in that legislation has been considered by this body several years, and we can point to why it didn't ultimately pass, but the fact is that the employer community in the Commonwealth was concerned about these proposals because it is directly regulating the benefits they offer to their employees. We already know that employers have trouble retaining talent, attracting talent, and one key component of that and one concern for employers is the cost of healthcare. So I would just keep that in mind going forward. I appreciate your time. I'm happy to take any questions.
Okay, thank you so much. I appreciate your being here, and thanks for being so fast and efficient. Sorry about the squeezing your time. I agree that we need more transparency around wholesale versus retail, cost and negotiated rates. I think that Sunshine would be a great disinfectant, and answer some of these questions, especially around markup of drugs and even the 340B program and rebates. Yeah. Do you have any comments about transparency and how we best achieve that?
Sure. Our industry is not opposed to transparency. There's a couple things. There's actionable transparency that leads to lower costs. There's transparency for plan sponsors. When we contract with an employer to provide their prescription drug benefits, they have full audit rights to make sure that we're living up to our end of the bargain. They're getting the rebates that belongs to them. For patients, some of these transparency measures is essentially a giant data dump, and nobody knows what to do with it. There are states, I think Washington and Oregon, passed some laws, pretty comprehensive transparency laws. All it was a huge data dump, and they still don't even know what to do with it. There's transparency for patients that we support, which is that we implement real-time benefit tools. So when you're in the doctor's office, the doctor can see exactly what drugs are covered, what drugs require step therapy or prior authorization, what pharmacies are in network, and what their cost sharing is going to be right then and there. That's actionable transparency. Transparency when we're talking about very granular data that discloses, proprietary confidential negotiations with drug manufacturers or pharmacies that would allow them to back into it and see what those rebates were. You end up with tacit collusion, which is actually what we're seeing at the federal level with some of the hospital price transparency measures they've passed. We're not opposed to it.
Yeah, well, I don't disagree that we have large data dumps and no central repository for that data or data analysis. So we're going to be working on that a little bit.
Madam Chair, just quickly, I would also add, there are several state laws that have passed that require PBMs to report certain data to departments of insurance, et cetera, and that's great. And we've complied with all of those laws. But what I've seen in several states is focusing just on the PBMs. If we want to talk about transparency, you can't look at one piece of the pie. We need to include pharmacies, drug manufacturers, wholesalers, PSAOs, PBMs, insurers, across the board. So last thing I'd add on that.
I don't disagree. And you didn't really talk about vertical integration and who owns what. And I know that that's been a very concerning piece of this. Can you comment on any of that?
Yeah, so you have some PBMs who are owned by insurers or vice versa. The big three are vertically integrated. I wouldn't say that's necessarily a bad thing. I think it's the same principle as Costco or Sam's Club. They are a retailer, they're a wholesaler. They do that to provide value and lower cost to consumers.
Okay, all right. We have a couple of questions. Representative Weber.
Thank you, Madam Chair. I have some information that I was given. I just want you to comment on this if you can. It relates to blood glucose level medication, Ozempic and Mounjaro. What I'm hearing is that pharmacies are not wanting to carry these particular drugs because they're not making a profit off of it due to arrangements between the pharmacy and PBMs. Could you comment on what effect this will have on insurance rates?
Well, I know that Wegovy and I think it's Mounjaro are also like the new weight loss drugs. Whether they're covered for that purpose or they're covered for diabetic patients, that's up to the plan. As far as pharmacies losing money, a lot of pharmacies use PSAOs to negotiate with PBMs for their reimbursement rates on their behalf. Those three largest PSAOs are owned by wholesalers. And so, again, we sit at the middle between payers and providers, and there's a natural friction. I guess what I would say is, you can't pay more and spend less. And I think when we're talking about reimbursement, at least as it relates to pharmacies, you also have to consider acquisition on their behalf from their wholesaler. So if they're not buying efficiently or prudently, I don't know if that necessarily means we should just pay them more.
Senator Berg.
Thank you, and thank you, sir, for this presentation. This is a subject that I'm very interested in, both as a provider and as a patient.
Mm-hmm.
And you talk about who your PBM clients are: private sector employers, public sector employers, commercial health carriers and government programs, union trusts, and Taft-Hartley plans. And you talk about the satisfaction that these employers have with your plans. What I don't see in this discussion here is the fact that the ultimate client is the patient. How satisfied are patients with their PBMs? Do you have any data on either physician-provider satisfaction or patient satisfaction with the model that you're presenting?
I'm not sure. I'm happy to look into it and provide it and send it to you.
All right, that's I think that's interesting, because ultimately we're here in the business of healthcare delivery to actually patients. And this is part of the disconnect that I'm seeing between PBMs and pharmacies that are community-based and providers and their patients, is that all of a sudden we have a structure in the middle telling physicians what they are allowed to prescribe, actually approving these medications and then turning around and unapproving them without even letting the providers themselves know that these medications are no longer being approved for their patients. I mean, we have some serious healthcare delivery issues associated with PBMs, aside from the marketplace, and certainly aside from the fact that our formularies are now based on rebates as opposed to cost and efficacy, which is unfathomable in my mind. And sir, I'm not done. The other thing is you have to incorporate the cost of patient safety. You're saying that these white glove procedures in one estimate save $2.5 million. You have one wrong dose, sir. One wrong chemotherapy injection into a patient, and that will cost you that $2.5 million right there. You haven't saved a penny for the healthcare system. So I just think these are things that people need to think about. It is not all a profit margin. It is how you actually deliver care to patients. And PBMs are falling down on that, sir. Patients are not getting their medications in timely manners. Patients are getting way too many medications that they shouldn't be receiving. And there is no transparency in your system as to who and what your companies are willing to cover. Thank you.
Just one quick response on the point that, you know, our clients are employers, et cetera, and we're not, you know, directly serving consumers. You know, if you look at the KTRS letter, their consumers, the beneficiaries, get to benefit from stable cost sharing, stable premiums. If that's not benefiting a consumer, I don't know what
They're not getting their medications and not understanding how to take their medications in a timely. That is the real problem for your consumers at this point.
Okay. Thank you, Senator Berg. Obviously, we are all passionate about finding a solution regarding the safety and delivery of health care for our patients, but also the cost of all of these pharmaceuticals. This is a good part of the discussion. So I appreciate your being here. It's an important issue. We have one more question, Senator Funke Freimeyer.
And I can support and encapsulate some of what Senator Berg was sharing. One of my physicians in Campbell County is here today, and I'm hearing a number of requests and concerns that our physicians, as if you were here for the whole presentation today, we began with the fact that we're desperately short of physicians in the state of Kentucky. And there's some recognition that our physicians don't have as much empowering experience with their patients. What they recommend or they try to guide patients on may or may not be covered by the insurance. So really only comments that I have to make, but we also recognize in my own small little county of Campbell, we've had 3 pharmacies closed. And that's a desperate situation for an area with 80,000 people that really kind of rely on their pharmacist to help. And the clawbacks and the rebates and the complexity, yet we're so sick. We're so sick. And the costs are through the roof. So I don't know that the actual benefit is being experienced by the payor, which is ultimately the family that is paying more for their monthly premium for insurance and dealing with complexity. So there's a lot that we'll have to unpack, and thank you for being here to share some today. But I think we're going to be digging into this much, much deeper so that we can bring some support and care to our constituents. And all of us, as you can hear, are pretty passionate about getting to the root.
Understandably so. And as you all continue these discussions around these policy proposals, we'll probably see next year. We are happy to be a part of the conversation. We want to be at the table and provide our 2 cents and make sure that any policy we pass is good public policy.
Yeah, thank you.
Thank you.
Okay.
Good.
Thank you, Senator. I guess one final comment. Sure. I think I'm going to disagree with you a little bit on your comment about the stability of the cost and the copays and the cost sharing, because just personally, monthly meds change every month. So I'm not sure who's in charge of that, but I don't think there's any consistency or stability in that system.
Okay. I'm happy to share with the committee some data on actual cost sharing, and I understand there's plenty of anecdotes around sticker shock at the pharmacy counter, but I think the reality is that that's a very small minority of claims at the pharmacy counter. In fact, I think IQVIA looked at this in 2021, and it was less than 0.1% of pharmacy out-of-pocket costs were over $125. And I'm not saying that that's a non-issue, but I think it's important to keep in mind that 99% of prescriptions are processed without issue at a low affordable cost with affordable cost sharing. Again, I'm happy to share that with the committee.
Okay. I could also share, my husband's experience with his diabetes meds going from $30 a month to $600, and most people can't absorb that. So, that's not an anecdote. I've got receipts. So anyway, thank you for being here.
Thank you.
I appreciate it. I do want to announce that the Kentucky Medical Association is hosting a lunch and learn in room 113 right after this meeting at 11:30. So come in and talk about the exciting issue of prior authorization. And then the next meeting of the Interim Joint Committee on Health Services will be Monday, November 6th at 1 p.m. And the meeting notice will be sent out today. I thank everyone for sticking around. We had some really important discussions today, so thank you so much to our presenters, to everyone who's here, and certainly to our members. Seeing no further business, I move for adjournment. All right, thank you.